I just had my first Arabic lecture when I was sitting in the audience, so I can say Salam Alaikum. And shukran again for having me. I was asked to talk a little bit about the management of hyperkalemia, and we had touched upon this point earlier, and it's a bit of a continuation on the comorbidity discussion that we already started. So first of all, I would like to start out with the clinical significance of hyperkalemia in patients with heart failure and overall the treatment of hyperkalemia in our daily life, actually. I would like to share with you one brief case study of a patient that I saw in outpatients in my hospital, and I would like to close with the new treatment options for hyperkalemia in patients with heart failure. So I personally like this quotation here, never be afraid of something new. Remember, amateurs built the ark, professionals built the Titanic. So I think it is really time to embark on something new, and this is exactly what we're facing when we talk about the treatment of hyperkalemia. So what is hyperkalemia? And I think whoever you ask in the audience, what is hyperkalemia, you will get a different answer from each of you. Because the threshold is first of all different in each lab, and the personal understanding of hyperkalemia may also differ. And for example, me personally, I don't like a 6 in front of the comma. But this is more a gut feeling and not precise science. Value of normal is somewhere between 3.5 and 5.0 or 5.1. So the studies included patients mostly at a threshold of above 5.1, but we only have data up to a threshold value of 6.5 approximately. And as you can see, there is an increase in the mortality rates when there is hyperkalemia, but also when there is hypokalemia above a certain threshold. And you can see that the values are apparently increasing already above a value of 5.5. So whenever there is hyperkalemia in patients with heart failure, there is also an increased risk of mortality in these patients. Hyperkalemia and mortality, of course, we do have the problem that patients require drugs, RASi inhibitors, that will increase the potassium value, and this is particularly true for spironolactone, but also for the ACE inhibitors or the sartans. So all these drugs will mildly or moderately increase the values of potassium, and so this is kind of a side effect that we still have to accept in a way. Now, how do we treat hyperkalemia actually? And we had a brief discussion earlier today. I think we must make a big differentiation between the acute setting where there are ECG changes already present in a patient presenting to the emergency department and patients with a chronic elevation of the potassium value. And as you can see, at a value up to 6.5, there might be tent-like T waves, and the higher the potassium value goes, there will be a prolongation of the PQ interval, possibly the loss of a P wave. Later on, at a value of roughly 7 to 8, there will be a prolongation, broadening of the QRS complex, and then there might be ventricular arrhythmias above a value of 8 and even asystole. So the treatment of hyperkalemia now is mostly done in the intensive care unit, and there are several ways of approaching hyperkalemia, and I'm sure that everybody who has done intensive care medicine has pursued several of these ways already. For example, there is the means of the stabilization of the myocardial membrane potential using calcium chloride. This has an immediate kind of onset of action, but this will only last for like half an hour. Then the next way to be pursued is a stimulation of the intracellular potassium uptake using IV glucose together with normal insulin, or the IV injection of albuterol. Again, these will only last like a shorter time frame, up to a few hours. However, what you can also use is in metabolic acidosis, you can use sodium bicarbonate given via the IV route. And of course, you can also exchange the potassium ions using SDS together with sorbitol solution, or you give via the rectal route also an SDS suspension, or of course you can use hemodialysis to get rid of the potassium. Now, potassium binders do have a role, but potassium binders do have a limited role and only up to a certain threshold. There's no point using potassium binders in a patient with a potassium value of above 7 point something. These patients require urgent treatment, and they do require more than a potassium binder. Now, the problem with the potassium binders is that the only potassium binder that has been available until very recently is sodium polystyrene sulfonate, SPS. And in Germany, the brand name of this is Resonium. And I'm sure that every cardiologist has used SDS at some stage when a patient on a normal ward has been present and had potassium value of 6 point something. So these patients may be treated with SPS. However, the problem is that there is a limitation for this drug, as it can only be used for a very limited number of days. For example, 3-4 days maybe, because there might be serious side effects, and you require a high stool volume in the gut for the potassium to be bound. The problem also is, are these SPS drugs good stuff? The problem is it tends to cause constipation, and it is usually given with sorbitol. And the other problem is it may cause even necrosis of the gut. Even though this is a rare side effect, it limits its use up to only a few days. If you see now a patient, like the patient who I have seen recently in the outpatient department, he's an 84-year-old man with terminal heart failure. I actually saw this patient last week. 84-year-old patient with a normal body mass index, normal blood pressure, and normal heart rate. He is a patient with ischemic cardiomyopathy and an ejection fraction of 25%. He has CRTD implanted. He has permanent atrial fibrillation. He is in New York Heart Class 3. However, his main limitation is fatigue, not so much shortness of breath. And there were no visible peripheral edema. Now, this patient took, when I first saw him in the outpatient department, already his ejection fraction was severely reduced. He took metoprolol, he took olmesartan for some funny reason I didn't really understand. He took toracimide, pantoprazole, kalium iodide, febuxostat, and fenprocomone, which is the German sort of warfarin that we are using. And now when I saw the patient in December 2017, the patient already had an NT-proBNP of 11,000. You can see there was a significant reduction of the kidney function. There was very mild anemia. And the patient was then started on sacubitril valsartan, so Entresto, so the olmesartan was stopped. But still the NT-proBNP increased over time until September. It had even doubled. The kidney function tended to worsen over time again. And you can also see that in March this year, the patient had a further increase in his NT-proBNP value up to 26,000. There was even mild decompensation, and the patient at that stage was admitted to have an upgrade to a CRTD device that was only implanted in March this year as a little bit of a desperate measure in this patient. And again, there was worsening of kidney function. Now, unfortunately, the patient had a reinitiation of spironolactone at that time. And this was really the patient's main problem, because in the next month, his potassium value had increased to 6.1. Now, of course, you can argue this patient is in need of spironolactone, but whenever he's receiving spironolactone, he's going into hyperkalemia. Now, the question is how to deal with this situation. And of course, I'm sure that everybody in the room has an idea how to deal with this. You can, of course, increase the dose of the toracimide. That might be one of the options. One of the options may also be to use one of the new potassium binders. And one of these is patiromer. The other is zirconium cyclosilicate. And these have been on the market for some time. I'll mainly stay with the patiromer because most of the heart failure studies have been done using patiromer. Now, patiromer is a drug that is ingested as a suspension via the oral route. So the patient drinks this, so roughly 8 grams, for example. You can increase the dose according to the needs. And you can also see that the drug is non-absorbed, so it stays inside the gut. And it exchanges the iron, the inside the molecule is exchanged against potassium. So the potassium is bound in the drug and stays in the gut. And is then, of course, excreted with the feces. So what the patient is doing is the patient stirs the content of one sachet into 40 milliliters of water, adds a little bit of water again, and drinks the suspension within 1 hour. And the PEARL-HF study is one of the first studies to look at heart failure patients, really. It was published already in 2011, and Stefan Anker is one of the co-authors on this paper. And you can see that there was administration of patiromer, and after that, patient received spironolactone. So they were started on spironolactone while being on patiromer or on placebo. You can also see that the number of patients was rather small, about 50 in each group. And these were patients who had a history of RASI discontinuation or a GFR below 60. So I think that my patient may suit here well. Standard treatment for heart failure, initiation of spironolactone during the trial, and the risk to develop hyperkalemia. What you can also see is that the drug, it was well tolerated over the duration of the trial, which was only 28 days. And you can also see that there was a significant decrease in the patient's potassium level while being on patiromer, and there was no significant, or there was only a very mild increase when the spironolactone started. So I think this is a very important message that you can use spironolactone even in these high-risk patients when you're taking care of the potassium changes. So these patients had a higher likelihood of having an increase in their spironolactone dose, and many patients were able to achieve 50 milligram daily of spironolactone. So a number of trials have been done, and I would only like to briefly touch upon the Amethyst trial, which is mainly a trial in patients with diabetic nephropathy. And you can see this is a dose-finding study, or has been a dose-finding study into the long-term use and safety of patiromer over 52 weeks. So, and I think this is also an important message, because in this study it was well possible and well tolerated to keep patients on patiromer for 52 weeks, so for out to 1 year. And the drug was still comparatively well tolerated. And the primary endpoint was a mean change in the serum potassium value versus baseline at week 4, or at time of first dose titration during the initial phase. Patients were patients of CKD and type 2 diabetes with or without hypertension who were on an ACE inhibitor or an AT1 antagonist for at least 28 days. One of the, well, you may discuss this, and I'm happy that Stefan Anker is here in the room, that all these trials have been done in an open label fashion. So what you can see is that the drug was well able to reduce patients' potassium level, and this was achieved very early after initiation of patiromer. So you can see that the patients in the moderate hyperkalemia group, here depicted in orange, they were starting at a value of 5.7, that they had an early decrease at day 3 already, and they were achieving values around 5, and then further decreased to values around 4.6. And those patients with mild hyperkalemia at study entry, they started at a value of 5.2 and then achieved similar values during the maintenance phase of on the drug. So, and with this, I would like already come to a close that RAS inhibition is, of course, a very important therapy in patients with heart failure, but also in CKD and diabetes. And it is often associated with mostly mild hyperkalemia. When looking at the trial data, I think you have to consider that these patients included, most trials have used an upper threshold of 6.5. So like 2 or 3 weeks ago, a patient came to me with GP lab values from the day before, and she showed me the GP's lab values, and it showed a potassium value the day before of 7.4. And the GP had done nothing but sending the patient the next day to the university hospital, which is unusual, I believe. But this patient would be outside the range of the trials that have been done. So I admitted the patient. And well, hyperkalemia, and we have seen those data, is associated with increased mortality. Available therapies have relied on dealing with the acute situation and, of course, withholding culprit drugs, like withholding spironolactone for some time or decreasing the dose. This is a standard that is also, of course, done in many patients. Withholding or stopping guideline-recommended therapies may yield increased mortality. And modern therapies of hyperkalemia, such as patiromer, can be used for longer times and are overall well tolerated. Thank you very much for your kind attention.